Greetings and thank you all for joining us. My name is Sanjeev Silva. I'm director of the Sapien Care session. So during the last 12 months, there's been a lot of added stress due to lockdown for many people. Children have been trapped at home, away from friends, often with ineffective online schooling. Parents have been trying to balance work and childcare, and many people have been out of work or furloughed with dire financial consequences. This has resulted in a mostly unspoken morbidity of depression and anxiety. General practice has been challenged with trying to manage these patients remotely. Today, we intend to explore the resulting extremes of this increased stress by bringing an expert panel to discuss drug and alcohol addiction and domestic violence. So as previous webinars, be reassured that this is all available online on demand. So if you have to leave halfway through, you can always come back to the content afterwards and review topics covered later. So without further ado, I'd like to hand you over to our chairman, Professor Stafford Lightman, to start the session. Thanks very much, Stafford.
Well, thank you very much, Sanjeev. So I should like to welcome both our regular attendees and those of you who are new to Sapien Care. Those of you who've been listening before will know that in most of our webinars, we've been discussing problems that actually existed prior to COVID, but that COVID has either magnified or spotlighted. Indeed, what our discussions have shown and made very apparent is how pre-existing inequalities of health and wealth have had a major role in determining the outcome of both the social and the health consequences of COVID. In the webinar today, we're going to be looking at two aspects of human behavior that have been strongly affected by the lockdowns themselves rather than the actual pandemic. Our speakers will discuss our problems of accessing support for either domestic or drug abuse will have been magnified by lockdown and what can be done to try and mitigate some of these. I also hope that we shall be able to discuss whether these experiences can provide lessons for improving our services in the future. Another aspect of our webinar today that's rarely discussed in an open forum like this is the vital interface between the police and the medical profession. There's been a tendency for some politicians to forget that alcohol is the most prevalent form of drug dependence, and conflating drug dependence with crime leads them to conclude that the only role of the police force is to act as crime managers. We also need to discuss the role of our police in safeguarding against violence and for child protection, which in turn shines a light on the sticky subject of how both the medical profession and the police adhere to different concepts of confidentiality and information sharing. To start us off today, we're very fortunate to be able to talk with Jean Fader, who's a professor of primary care in Bristol Medical School. Jean actually started his research career with his MD on the health and healthcare of traveller gypsies, but now his current research program focuses on healthcare responses to domestic violence. So Jean, please, you're going to tell us about domestic violence during lockdown. Thank you.
Thanks, Stafford. So domestic violence is a violation of human rights, often a criminal act. Why should a doctor, why should a researcher, a clinical researcher be interested in it? The reason is because it has a profound impact on health, and it damages health severely, both acutely in terms of acute injury, but also long-term mental health and physical health. So it's a perfectly appropriate focus for epidemiological work and looking at what kind of interventions within healthcare we can bring forward to mitigate the effects and prevent domestic violence. Stafford, you've used the word magnification, and it's spot on. There are two ways that domestic violence has been magnified in during the pandemic. The first is precisely that something that has been there and has been part of our society, often visible, has come into focus. It's become more apparent. And the other is that its incidence has actually been amplified. So there's this sense that what was always there has become more visible, like other inequalities, but actually the behavior itself and the phenomenon has become worse. I mean, the way I think about domestic violence is through a sort of ecological model, because when you think of the causes, they go from the personal at a very individual level of individual behavior, perhaps linked to childhood adversity, but also goes right up to the structural. And by the structural, I mean economic inequality, which drives abuse and violence. I also mean the fact that we live in a patriarchal society where abuse by men against women is something that historically has been woven into our culture. I'm not saying that men can't also experience domestic abuse. They do. They may experience it from other men if they're in a same-sex relationship, and they may experience it from a partner if they're in a heterosexual relationship. The reality is that the severity, the repeated nature of abuse, and its impact is worse for women than it is for men. And most of my research does work at the level of women who are experiencing and victimized by domestic violence, although we also have work around men as victims. Now, the issue of the pandemic, again, as Stafford has already highlighted, is not necessarily the direct impact of COVID itself, but is the impact of the lockdown. And it's the impact of living in a pandemic infiltrated society where that can also be used by abusive partners to control their partner. And can I just segue for a moment to say that when I talk about domestic violence, I'm not just talking about intimate partner violence. In the UK, domestic violence includes violence from or abuse from another adult living in your household or as part of your family. And that's an even more hidden aspect of domestic violence than intimate partner violence. So what's happened during the pandemic and what's happened globally, because when we use the word pandemic, we do mean more than one country around COVID, and we certainly mean it in relation to domestic violence. The prevalence of domestic violence globally is about a third. So a third of women have experienced some form of particularly intimate partner violence in their lifetime. And the incidence varies, the annual rate varies between 10 and 30%. So the use of the term pandemic is not metaphorical. It's actually actual and empirical. And that has increased. So the incidence has increased, particularly measured through calls to helplines and police reports. And I know Raj is going to talk about the police response in a moment, so I'm not going to talk about that in any detail. But by any measure of survivors reaching out for support, there has been an increase globally. Paradoxically and worryingly, from a healthcare point of view, the reporting within healthcare settings has actually gone down. So emergency department attendance, which has actually gone down across all presentations, has gone down in relation to domestic violence. And for instance, in Brazil, where there's epidemiological reporting from healthcare settings, there's a third decrease in the reporting of domestic violence. So there is this disconnect between what we think we know about the incidents and what we're seeing within healthcare settings. You might ask, well, what about some good epidemiological surveys to nail this measurement? That's difficult. It's difficult to do surveys where domestic violence is measured, even outside of a pandemic. There are all kinds of safety issues when you actually submit, when you send questionnaires into families to measure domestic abuse. So at the moment, we don't have good epidemiological measurement, but we do know that the incidence has increased. So what about the healthcare response? Well, before I finish with that, and Stafford will be glad to know because I think he's timing me here. Before we talk about the healthcare response, I just want to summarize something about the impact of the lockdown on people experiencing domestic violence. What are the mechanisms at work here? Well, there's severalfold. The first is that being trapped at home. So work and school can be a way of getting away from an abusive household. That route out, daily or weekly route out, doesn't exist during lockdown. Not having face-to-face contact with friends and family can be absolutely devastating because the abusive person within the household may already be trying to cut you off from support from friends and family. being able to lock you in to home through societal demand is a way of making that even more real and more powerful. The second mechanism is an assumption that support services are not available, which isn't actually true. In most countries, some form of support for domestic violence has been available, and certainly that's the case in the UK, although they've migrated more online, which is very difficult if you don't have access to online mechanisms. The third, which I hear as a GP all the time, which is I'm talking to a patient on the phone, and the first thing they say is, I really don't want to burden you with this problem. And I'm saying, but actually that's my job. And that's true with presentations of chest pain and weight loss. It's also true for presentations around abuse, which are anyway more difficult to disclose if you're a patient. So the sense of not wanting to burden the NHS is very real, and it's very out there. Economic pressure on households. We know that increased economic pressure is related to increased domestic violence. The increased pressure from continuous childcare, that's another way that a relationship that's already problematic and in trouble, and where there's abuse, that's amplified through the stress of that. Interestingly and worryingly, what I saw clinically is that families that already had split up and where the abusive partner was no longer living with the family, the lockdown actually gave him mechanisms for increasing contact again and manipulating the situation of contact. So the lockdown was an environment within which it was possible to be abusive again through child contact. And then finally, the COVID-specific thing, or the infection-specific thing, is manipulation of infection risk by the perpetrator has been used, and we have now data on this, to increase coercion. So there are lots of ways that the lockdown and COVID actually amplifies. I want to finish now with just talking about the impact on healthcare professionals. The first impact is that it's more difficult in a remote consultation to recognize that your patient is being abused. It's more difficult for them to disclose, particularly to disclose safely if there is the abuser in the household. The additional skills and competencies of managing telemedicine is something that in general practice, and I know in acute medicine as well, we're just learning how to do. So managing the nuances of a consultation where there's hidden information is more difficult. We don't have training in how to do that. We're trying to improve that through a research program that we're running at the moment. There is the issue that the domestic violence itself may be hidden by other causes of anxiety in a pandemic. I mean, most of my consultations at the moment are saturated with the anxiety of my patients, and the domestic violence may not be visible in that. There's also just the fact, this is more from my acute medicine colleagues, the increased workload within the healthcare at the moment, which makes it more difficult to deal with some of these more difficult and challenging issues. And then, of course, there may be your own personal experience of domestic violence in your own family, which may make it difficult to ask. So it's a major challenge. I'm going to wrap up now. We are working from a research point of view of trying to develop a way of working remotely and providing the safe space for disclosure, which we feel healthcare has an important part to play in helping survivors seek help.
So, Jean, do people find it more difficult to talk to you remotely than to come to your clinic and see you? I mean, does it actually make you more available or less available?
Good question, because in some ways it makes us less available for patients who actually find the remote consultation by audio video kind of uncomfortable. But you're right that there are a group of patients who actually feel that they have, in a sense, more direct access to you by being able to have an audio or video consultation. I still think disclosure of one of the most stigmatizing things that you can disclose, i.e. that the person who loves you the most supposedly is actually abusing you, I think that's still very difficult to disclose remotely in an audio consultation or video consultation. I think that is easier when you're in the same space as your doctor or your nurse.
And the other thing that crosses my mind is this must give you a real difficulty if you think that there's a problem with children and safeguarding the children. I mean, how How do you actually approach that remotely?
So we've actually developed some guidance around the safeguarding question, because, I mean, being exposed to domestic violence in your home is a form of child maltreatment. And there are other forms of child abuse and child maltreatment which also are difficult to see if you don't have the child in front of you. So the things we try to recommend in the guidance is that the consultation can be with the child as well. So I'm not talking specifically about domestic violence. I'm talking about children whose behavior is problematic, where you're wondering whether there's some form of maltreatment going on. So we do sometimes start that with a video consultation. But I have to say, Stafford, I have a very low threshold for asking the parent and the child to come in. And I do see children, GPs do see children, and indeed patients with presentations of mental health problems. We do have a low threshold for actually coming into the room with us. We're masked up, we have PPE on, but we do have a consultation in 3 dimensions. I think it's really difficult. Raj had a question, Raj Prasad had a question here, which maybe we should ask him to pitch, because it may be around how we manage mental health presentations in this context as well.
Sure. Raj, would you like to ask your question?
Yeah, obviously, I'm very interested in the mental health aspect. And I think this is an issue that Raj Kohli is going to come in on, because when the police arrive, the family therapy view, and I bow to the superior knowledge of many of my panelists on this issue, is that domestic violence is often what's called a systems issue, in the sense that it's not the case that you've got one terrible perpetrator and one victim. The victim is often contributing to the system by, for example, hanging around when they could have other avenues of getting out. But the question I was wanting to ask more, again, a difference between doctors and the police is, we know that there's a thing called community policing, which is extremely important. The notion that the community have intelligence, they know what's going on out there, and the relationship between the community and the police is vital. So I wonder what we know about how the community often knows there's domestic violence going on in its midst, and what we know about their abilities to do anything about it, because that's crucial. It seems to me this resource that is the community is often neglected, and the police learn the hard way that if you have impaired relationships with the community don't come and tell you when there's crime going on, and the community are the crucial intelligence system. And I wonder whether that also applies to domestic violence.
Yeah, I'm not sure. But by the way, I think we differ on the systems view, but I don't think this is the place for me to throw that back at you. But I think it's an important point about community. Where our research is focused now isn't so much community in some abstract sense. It's around friends and family, and the dilemma that friends and family are in about how to support the survivor, and indeed at what point to, if you like, break the confidentiality of the survivor. This is a dilemma that doctors have as well in relation to talking to the police, perhaps even talking to them anonymously. So I think you're spot on that it's that it, and we can maybe talk about this more when Raj does his presentation, because that connection between the healthcare response, the family and friends response, and the police response is problematic and is challenging. And if we're going to have if you like, a multi-sectoral response to domestic violence, those lines of communication between the police, healthcare, friends and family is crucial. So I think you're spot on there.
I think this is just the ideal time to bring Raj in. Thank you very much, Jean. But do hang around, because I'm sure we're going to come back to you later on in the webinar. So my next guest is Raj Kohli. He's the Chief Superintendent and Borough Commander for Hounslow. Raj is known to have strong views on achieving legitimacy of policing and the importance and encouragement of self-policing rather than a more heavy-handed approach. This brings us to the key issue of how to manage antisocial behavior, which would appear to be a much more difficult issue than managing crime. So Raj, perhaps you could tell us a bit about what you think is the role for the police in domestic violence.
So, clearly, first of all, good evening to everyone on this call. It's great to be with such a valuable panel. First and foremost, I'll echo what Jean said, that I will talk about female victims of crime. But that's not to say that there aren't male victims of crime, but reality that society, the dominant discourse is male and paternal, and that the reality is that you're far more likely to be a victim of violence if you're a woman than if you're a man. So the role of the police is crime prevention, essentially, and then when a crime's been committed, to solve that crime. And so that in its basic sense is what policing is there for. Now, over the years, policing has become more nuanced. We recognise that, as Dr. Prasad mentioned, we need to have a better relationship with the community, because we're not pure prosecuting anybody if we're not getting the intelligence or indeed the evidence. So our role is crime prevention and then crime detection and prosecution of perpetrators. But I wonder whether society is in a position of being more nuanced around domestic abuse in its widest sense. For now on 30 years, I've attended calls or aware of calls where women, female victims, do not want their loved ones, for want of a better phrase, to be arrested. They just want the crime to stop. And they'll often go back because they know nothing else. And there's some psychological grooming potential going on there, but they just don't want their loved one to be arrested. So we choose things like domestic violence protection notice orders, which essentially means, Stafford, your wife tells us that you're abusive towards her. She won't give us evidence, but we believe on the balance of probabilities that you're a risk to her. We're going to serve you a notice. If you turn up at your house, you're going to get nicked. So what we have there is a sort of a hybrid between not arresting you and taking you to court, but arresting you to protect your wife, should that happen. But I do wonder whether that's even enough, because Stafford, you're going to be around on this planet for many, many years. How are we as a society going to manage your behavior? And I wonder whether we need to have that conversation, difficult, controversial conversation around perpetrator programs. There are plenty of programs, rightly so, to protect and look after victims of crime, quite rightly so. For perpetrators of crime, we do very little, if anything, with perpetrators of domestic abuse, questioning why they are abusive. Is this learned behavior from their own father, usually? Is this about drug or alcohol addiction? Is it mental health? Is it stress, or whatever it might be? None of these things are there as used as an excuse for that behavior, but recognition that we might, as a society, be able to help that person be healthier, so that if and when, and usually when as opposed to if, they start a new relationship, that person in a relationship with is not at risk of being domestically abused. And I don't think society really wants that or really understands it. I think it's a binary position. It's either we don't want to know, we pretend it won't happen, don't want to get involved, or throw them in prison and lock away and throw away the key. And I think that's a binary position that society takes. More widely, so we talked about online consultation. There is, and I'm with Jean on this in many respects. To me, it seems counterintuitive that how can you talk to somebody and really get the full picture when we know that 80% of communication is body language? Well, you're not seeing 80% of communication through this medium, so how does that really work? There is some research, though, that shows that use of online surprisingly makes people more likely to report difficult situations because of the anonymous nature of that transaction. And there's some research being done in, I believe it's either Sussex or Suffolk. There's some research being done in that space around better use of apps. Now, I'm not a fan of apps in that kind of business. I'm traditional, let's meet people face to face. But there's some research that says the use of apps might better paint the picture of where domestic violence is. So policing comes away from this online stuff, and we actually use body-worn video. So we're back to basics. We're recording the conversations we're having with victims of crime. And when that victim of crime says, I don't want Stafford arrested, prosecuted, I unfortunately am saying, well, I'm sorry, I've got it all on my camera. He is going to be prosecuted. And so we do pursue victimless prosecutions. So that's what we do. We're there to prevent crime and to detect crime when it happens. But domestic violence is more than just partner on partner. In fact, it includes sibling on sibling and includes child on parent and parent on child. Obviously, it's child abuse if the child is a child. If it's an adult, it becomes domestic abuse. But in the main, my worry is about the overall safety of women by men who, frankly speaking, are the problem in the vast majority of situations I see as a police officer. And I know that Jean said that not all men are that way inclined, but every single man has a responsibility to step into that space and say, your behavior, your attitude towards women is just not safe or right. That's wider than just domestic abuse. You can see it, wolf whistles on the street, ogling men, all that kind of behavior. It's animalistic, it's uncivilized, it's not becoming of human beings who are supposed to be intelligent animals.
Raj, can I ask you how much interaction there is between yourself and primary healthcare? I mean, there's this problem of confidentiality, and I'm not clear whether the concept of confidentiality in the police force is the same as what it is to doctors, and how you can work together more easily.
Really difficult space. So if I need your wife's medical records, as she's a victim of domestic violence, she has to authorize it. And I can't remember, there's a form, she has to sign it, and I take it to the doctor and he or she releases the information. Now, of course, Hippocratic Oath is around, keeping people alive, essentially, and you could argue that a doctor is failing the Hippocratic Oath if they know that that person could die and they're not reporting it to the police. Now, that's a really controversial statement to make, because the flip side of that is that woman is not going to come to the doctor and disclose anything if she thinks that her loved one's going to get grassed up to the old bill. But I do think that there's got to be a happy medium there, that I think doctors can and I think should do a risk assessment and balance up the pros and cons around the risk to the individual by not reporting it. And it's a difficult space. It is a really difficult space. I get the whole bit around confidentiality. My job is to keep people alive. The job of doctors, nurses, and healthcare professionals is to keep people alive. If that's our aim, then surely everything we do has got to be designed to deliver that.
Well, I think we'll come back to that later. I think actually it would be quite useful now to move over to Anne Lingford-Hughes, because this is all tied up and actually tied up with what Raj has been talking about as well. So Anne is head of the Centre for Psychiatry and Professor of Addiction Biology at Imperial College London. She's actually written the guidelines about the pharmacological management of substance misuse and addiction, and has described the comorbidity of addiction with psychiatric disorders. She's also contributed to the NICE guidelines regarding pharmacotherapy of opiate detoxification and alcohol misuse and dependence. So Anne, you're going to tell us about drug abuse during lockdown.
Yeah, thank you very much, Stafford, and thank you very much for inviting me to take part of this very, very interesting discussion already. I'm going to focus on substance misuse. So as Stafford said, I'm actually a consultant psychiatrist. I work actually in addiction service in Brent in London. And I've had to do all of my clinical works since last March via Zoom or Teams or various other virtual platforms, which has been a struggle. One is obviously haven't seen team members face to face, but also it's been challenging for us to really get that sense of somebody, what they're like and where they are. Some of my team, most of the team have been going in. I'm just one of the few that hasn't been, just to set sort of the context really of my experience. It's interesting this lockdown because actually alcohol alcohol in particular has been in the news quite a bit, and the Royal College of Psychiatrists have been really heavily at the forefront of that. But just saying that, you know, from the data that we're getting, alcohol sales have gone up. We estimate there's something like double the amount of people drinking at risky levels, so that's 8.5 million. We've got that on a background of addiction services over the last decade or so that have had their funding cut by sometimes up to 40–50%, on average by 20%. We've had addiction services moved outside the NHS now. We've had a number of training posts from 60 down to about in their 20s. So we've got this rise in people using alcohol, to us wanting hopefully to present to a service that actually was in crisis before COVID and is now even more so because we've got to do lots of things remotely. So that is a real challenge. And what struck me at the beginning of this process was those people who were in the service and treatment and were in groups and everything, the majority of them were able to adapt and get onto virtual platforms. But we spent a lot of time in the first few days trying to make sure that people had Wi-Fi or had internet or a smartphone or some way of connecting with us. But actually phoning people at home or contacting them at home when maybe their family didn't know they had a drug and alcohol problem was a real issue. Talk to confidentiality came up. Well, it was a real problem for some of our clients who just felt unable to take any calls like this. On the other flip side, there was, of some people, it was their first time they'd actually disclosed to their family there was an issue. And actually the initial part of lockdown gave them that space, I guess, that they were able to make some changes with the support. And actually those that could, join groups and extra were great. But we did then saw how the technical advances of having Wi-Fi, internet and all that kind of stuff and a device that you could do it really polarize the availability of people to join treatment. And I think we've seen this cultural divide, this sort of technological divide growing in disparity. And I think that is a real worry as we sort of go forward. The other thing I found extraordinary was that some people said, right, I do want to stop drinking alcohol. But there was the feeling that could we safely detoxify people, i.e. help them withdraw safely? Because if you're drinking really heavily, you are at risk of actually having a seizure or a fit or some other severe complications. And so often we'd want to bring people into treatment, we'd want to see them. What I found extraordinary at the beginning of the lockdown was that rather than think, how can we medically manage this safely, there was a discussion about buying our patients alcohol, which is a complete turnaround, really. We could say it's akin to giving a heroin substitute to heroin addicts, but it was the first time I think I have been faced by this. It didn't quite happen, but a lot of people couldn't detox or receive treatment because we just couldn't see them enough. They didn't want to come out of the home. This was during the first lockdown. This has now changed as we've gone on, and this has re-established itself, and community detoxes are happening. But this was right at the beginning. And if you remember, very quickly at the start of lockdown, March 2020, off licenses became essential services. And this was the same in most of the Western world. Off licenses became essential. And if you think about what's happening in South Africa with their lockdown, they shut down off licenses and ability to buy alcohol, actually to protect the health service. I think that we also, we also know how much adverse impacts of alcohol impact. So for alcohol, in my personal experiences, we've had some patients who've actually taken this opportunity and actually have done really well. For the first time, they've been able to get quite a bit of sobriety under their belt, have been able to join groups remotely. But I'm also aware of a lot of people we have not seen. Just touching a little bit on the domestic violence, because for many of our clients that is an issue, and for many of them with children at home, often in crowded accommodation in London, this was a real struggle, and it has been really difficult to try and work out how they are, particularly when a lot of these children weren't going to school initially. So I think from an alcohol perspective, there's just one other thing. So one of my PhD students has been looking at why, when you look at, whilst there are more people who are drinking riskily, not everybody did change their drinking. But when we looked at why people were drinking more, it is those with raised anxiety and depression and raised levels of drinking to cope. So they have found that alcohol, which is one of the most widely used psychoactive drugs, one of the best anxiolytic drugs we have in the world, is actually helping them feel better. But of course, that's going to come back with interest if they can't get on top of their drinking, and they're starting to lose control. As already said, this is going to be a challenge of people coming forward to services. So unfortunately, it does look within the group that are drinking more, it is because of mental health challenges, and they found that alcohol helps them. And so we are going to have to find ways of dealing with this. If we just move away from alcohol to other sort of areas where the addiction services, I mean, they were really set up to deal with heroin addiction. And so the majority of people in treatment in a traditional addiction services will be heroin addicts or opiate addicts. So we were faced two things at the beginning of this. For a lot of our risky clients who would have to come to the pharmacy every single day and take their methadone in front of the pharmacist, so they'd be witnessed, that obviously was not going to be possible. And so they went from being supervised to unsupervised, maybe having fortnightly prescriptions, so completely different. They were being allowed to take methadone, the main substitute drug we use, home with them in a way that went against all of our training. And I can tell you the staff multidisciplinary team meetings and the discussions about letting go of this, when we felt, is this really going to be okay? Is it going to be safe? There's children at home. How many boxes have we got that they can lock their methadone up? All of these safety issues. We had a lot of people, driving around, the key workers driving around trying to find some of our clients, give them all this equipment, gives them their prescription. You remember at the beginning, there was lots of volunteers. Oh, I'll help with prescriptions. But these are controlled drugs. We couldn't just give them to anybody, a pile of prescriptions. So it had to be key workers. A lot of our key workers didn't have cars. There was a lot of automatic. One service decided to buy all of their clients' smartphones. Unfortunately, that didn't really work. As you can imagine, they might have been used as currency for buying drugs. So that was the first thing, was we went from supervised to unsupervised, because actually you couldn't have people waiting outside pharmacy. Pharmacies didn't want to open. Pharmacies then couldn't deal with the capacity of having a lot of addicts. A lot of our addicts, data from the US has shown, is they've got an increased risk of infection of COVID, increased risk of complications. The last thing we wanted a lot of our addicts was out and about on the street. So that was the first thing. The second thing we tried to do was give them a safer drug. Now, methadone is a really good opiate substitute, but unfortunately, it's something called a full agonist, whereas if you take too much of it, it does stop you breathing, and it's respiratory depression that is what kills most people. There is another drug, a substitute called buprenorphine, which is only partial agonist. And what that means is it doesn't stimulate the respiratory system to the extent that it stops you breathing. So it's a safer drug. So we were encouraged to switch everybody to buprenorphine. A lot of clients didn't want that. Some of the new starters did want it. So we went from about 70% methadone to about 50% methadone. And that switch, we hope, helped to save some people, because it's unlikely they're going to cause an overdose death. That was from the first lockdown. Over the time, everything's sort of drifting now back to more people are able to receive supervised, because pharmacies have got capacity, and more people are now wanting the methadone. What we didn't see was a real rush into services. We thought, because of lockdown, because the first lockdown was so strict that obviously dealers really didn't want to be out on the street. And actually, whilst we heard of dealers with sanitizing and only using cards to payment and all these kinds of things, they obviously didn't want to be out on the street so much. And we didn't actually see a huge rush in. Some people did seem to manage their addiction from home. We know that a lot of people switched to other drugs, such as cannabis or alcohol. And also, people did seem to get a sufficient supplies of cocaine, etc., all the other drugs they want. So lockdown produced many structural challenges to our services. There were lots of things that were more difficult, but over time, I would say that we've managed to pull in the really high risk people and seen them face to face, 3D in the room. Services are beginning to get back to normal. We've tried to deal with this technological divide and disparity to deal with a lot of the difficulties that people had. But whilst many people have found it as found some positives out of it, I think that the challenges are immense, and they're going to increase, I think, particularly around the alcohol, when people realise actually maybe they can't change their drinking behaviour, and we need services to be accessible and available to them. So thank you, Stafford.
So, I mean, basically the need is going up, the services are going down. And so even when we come out of this, we're going to be in a much worse place than we started.
That's potentially, yes, the case. I think there'll be a lot of people who may not feel that they need maybe to see a psychiatrist or consult psychiatrist. There are lots of peer support groups and a lot of other, AA and others where people will be able to get access. There isn't going to be the bar, but I think it is that comorbidity. We know the rise. So America has seen more deaths. I couldn't find the data from this country from opioid deaths, but it's likely to have gone up. Alcohol deaths are definitely rising. So it's not just the addiction services in there. We don't have trained staff because, the need is rising, and we do need to do something. But that's been, many of us have been arguing this for some years. There's a glimmer that this government may do something different, a glimmer of hope.
Well, that would be good. Actually, it's a really good point to bring in somebody from the other side of this. This is Robert Powell, who actually works with us in Sapien Care. Robert's an alcoholic in recovery for 9 years, and he's secretary to an AA meeting in Haringey. And he's got a lot of experience about what is happening amongst alcoholics during lockdown. And Robert's just going to very shortly tell us a little bit about what his experience has been. Robert.
Yeah, hi Stafford, thank you very much. And Anne, that was very insightful. I've been in recovery for 9 years, and I don't think I've ever heard somebody from your side of the addiction world talk, actually, and your experiences are not massively dissimilar to mine. So I run an AA meeting. It's actually in Oakwood in North London, and our numbers through lockdown, we've stayed open. The first lockdown we weren't allowed to open, but since I think probably the first lockdown we've been open, but we have been limited in social distancing and limited in numbers of the people we're allowed to hold within the room. But our numbers are down drastically. We're probably down by about 60%, 70%. We've lost 2 of our members over the last month to suicide. And these are people who've actually found recovery and generally are through the other side. So that's particularly sad to experience that. I think what's really important for people to try to understand with addiction, I talk much more from the alcohol side of it, although I am aware of the drug side of it. And I agree very much with what you said about heroin and the high risk substances, but there's also a middle band of things like ketamine, MDMA, which the streets are absolutely awash with. And you see the Uber Eats drivers and Deliveroo drivers on their scooters delivering pizzas and McDonald's, and I can tell you absolutely certain that's not all they've got on their mopeds whizzing around the streets of London. They're providing a wonderful service to addicts as well. So that has definitely been on the increase in my experience. And we've had a couple of newcomers come back as the lockdown started to wind down, but we're talking 1s or 2s. The problem that I see with addiction is there aren't clear lines about what addiction is and where it falls. Is it a mental illness? Is it this or is it that? It's a number of things. It's extremely complex. It's not a simple thing, as you'll well know, and you're quite right in saying that the facilities for addicts these days are a few and far between, and it generally falls upon the NACAs, AAs, and the rest of the AA meetings and volunteer organisations to offer sort of group therapy and support. But addiction is generally a certain people would say it's a loss of connection with things, a loss of connection possibly with people, life, reality. And addiction tends to send people into their own heads. So lockdown has been wonderful to feed addiction because it's enabled people to isolate. When they're isolated, they're only listening to their own thoughts and their own ideas. And when you're in an addictive state, very often you're in a very delusional state. And what you believe to be real isn't. What you believe to be good isn't. What you believe to be healthy isn't. And I think this has created a real breeding ground. And I think we're yet to see what the full effects have been from COVID.
That's very helpful. Can I just last thing that Raj Baso's got a question to come in just before Raj asks. The alcoholism is very much an isolating illness. What effect do you think lockdowns had on that in terms of people's lack of contact with family and friends and connections? Is this a major problem?
Absolutely, absolutely. Without a doubt, one of the guys we lost, a 32-year-old man, where normally his brother or his mum would be around checking up on him, how are you, making him go to meetings, making him get up and get dressed in the morning. He had none of that for a period of, I think it was about eight weeks. And in that time, he fell very much back into his old behavioural patterns. And whereas families would normally see how you look, and families generally, not always, but are often quite straight talking. And my God, you don't look well. Will tell you lost a lot of weight or you put a lot of weight on. They will say, and I think that lack of intervention from family and friends as well, because that's another significant part of it. And one of the successes of the AA network is this idea that you build a network of fellows, of equal people, if you like, who all kind of look out for each other. And those networks have just crumbled and fallen apart. So where there's normally support from other people, it seems to be lacking. And that's not really been taken into account, I don't think.
Thanks, Laura. Anne, is there anything you'd like to say in response to that at all?
No, I mean, I think AA has been a remarkable facility for a lot of people, and I think, or NA, all of the A, and I think this, what you're just talking about, Rob, about that network. I mean, it is so important that addicts have a network that is away from their drug or alcohol to get support. And I think, that's what, this organisation is absolutely brilliant at doing. And I think it's, as you said, that social isolation has been really, really tough for people. And I think that's just added on to that difficulty. I mean, my experience is that is getting better now, but I think that first lockdown was pretty brutal. I think the only glimmer for a lot of people, they said, was they knew everybody else was in the same boat. They felt part of a different community. There was a collective. They knew that other people were struggling. I know that sounds odd, but do you know what I mean? But I think you're right. I think this inability for people just to pop in or have that conversation with the newsagent, that some daily contact with an outside person has been devastating. And I'm really sorry to hear about the losses you've had in your group. That's really difficult.
I mean, you pointed out the Zoom meetings, and I was stunned by how successful they were. But I think the problem was it only suits, a small percentage of the people. But the people who did engage in the Zoom meetings, I will say this, it's been ever so successful. And the A's adapted pretty much like so many other organisations did in rolling that out as a platform for connection. But that relies upon you, being accountable and taking responsibility for yourself to do these things. And I think what Stafford was asking is that most addicts and alcoholics need someone looking out for them and to push them into action, kind of thing. Once they get there and they realise it's on their own steam, they must now travel. They, a lot of them do well. But in the early days especially, they need that sort of push and support from outside influences.
Yeah, I just say it's very hard to start, isn't it? And I think that's the difficulty. I think those that were already in existing groups found it easier to come together, but telling people to join was really tough.
So Raj Baso, you've got a question?
Yeah, it's a question that the last two speakers have kind of highlighted, that the lockdown and the pandemic had a big impact on vulnerable people. There was a double whammy in that services became very difficult for vulnerable people who needed them to get hold of, and the services found it difficult to adapt. But the lockdown and the pandemic had a direct negative impact on these vulnerable people. And you could say that the mentally ill and addicts and the vulnerable people in this situation were paying the price for the government policy of the lockdown. And I wondered what the last two speakers felt when they were looking at the news every evening with government advisors talking about the statistics and the graphs over the infection rates and the death rates, but no data being presented about the impact on people in terms of mental illness, addiction, and so on. So there was a sense in which there was a secret underground almost impact of the lockdown that you two were seeing, but was getting very little publicity. Did you get a feeling that the government either wasn't measuring this or paying attention to it, and it was kind of like being brushed under the carpet? What were your thoughts about the fact it seemed to me we were getting a very unidimensional picture of what the government was obsessed with, when there were lots of other things we should at least be becoming aware of with the implications or the impact of the lockdown?
Do you want me to go
no,
first?
You go first, Robert. You go first.
Yeah, I mean, I must say that the number of times I asked that question, Raj, to myself, watching Sky News every evening is where's the data? Where is it? Because I could see it and I could feel it. We knew what was going on. I have seen a couple of news articles actually on data, but the data's going back to April of last year, and that showed that alcohol-related deaths were higher than ever recorded. But that's a year out of date. I've not seen any data on mental health or addiction since, and they definitely don't want to produce it, because it's not going to. And the same with suicide. I'd love to see what the suicide rates have been. I'm pretty sure I know what the answer would be. What was Anne's view?
Yeah. So coming back to the data, I mean, of course, a lot of our data from our drug and alcohol comes out from PHE, which of course was tasked with doing something different. And of course, as PHE has now got disbanded, we're not quite sure what's going to happen to drug and alcohol. So actually, the reorganization of PHE has left a lot of us thinking, well, where are we going to be? The data that has been all over the media the last day or two, led by the Oxford group, looking at the largely American data, the risk of substance misuse has gone up for those that are coming out from COVID. But I did ask very early on whether people were seeing more, was it potential abuse of opioid analgesia going to come around? Were people using a lot of opioid analgesia to recover from COVID? I was told that wasn't the case. I haven't seen anything up to date. This was one of the long-term big research studies, cohorts that are going on. But I do agree with you around the mental health. I have to say there was both my clinical side, which was also thinking about some of my clients, so that's our nomenclature in addiction services, not patients, that had maybe lots of children, maybe one or bedroom, they're not at school. And I was thinking, how on earth, is this all? We just knew that this was going to be really, really tough on them. I have to say, at a personal level, I had a father with dementia in a care home, and that isolation, and what angered me actually wasn't just about the whole lack of discussion about mental health and how to optimize it in this difficult situation. Got some airtime, but I didn't think it got enough early on. And I think what's important about our research and others showing that alcohol's consumption has gone up in those with anxiety, depression, drinking to cope. That really should be a marker now. We should be targeting, we should be letting people know, not the pubs are open, as the Prime Minister, he's going to go and have his first pint on Monday. I think we're missing a trick.
I wonder if Raj Kohli's had this sort of experience too, whether or not the police have seen major changes over this time.
Not directly, because obviously the nighttime economy and sort of associated disorder you get with drunk people public spaces. Not really. We probably have seen a minor increase in terms of neighbour disputes, where when we turn up, people have been drinking, and certainly from social media, there's now a movement from people who recognise that they've slipped into drinking far too much, almost without notice. I just want to say to Robert, I was really heartbroken at those two friends, that, especially when they were on their way to recovery, not being with us today. And that, I think, is a really sobering, salient point of how vulnerable groups have been missed out in the world of graphs that we were subjected to on a daily basis up until quite recently. And I think missed a trick, really missed a trick. But to your question, Stafford, not yet, but when we go into full lockdown release, I do worry about caged animals being released, which is a really clunky, unfair term, but it's kind of the one I go to because that's what sense might happen.
Stafford,
yes.
Can I just make one point? I think that the one aspect of the government at the beginning was about bringing homeless population off the streets into hostels initially and hotels, and a lot of my colleagues spent a lot of time, doing the prescribing, doing health checks and everything. I think, if we had to look at something that was good, and homelessness were then put on the category in order to get vaccination, and those, and obviously a lot of those people would have drug and alcohol problems, and I know some have turned the corner, some haven't, but I think that, of course, now question of how do you deal with that, they go back on the streets, etc. But I think that was one glimmer, really, that we should learn from that and what worked about that.
Jean, we haven't talked much about what's been happening in domestic abuse and whether or not there's been an increase in suicides and things like this. Have you noticed, or do we know exactly how severe things have been getting?
Well, we know about the severity or the increased instance of domestic abuse now, but suicide's a really crucial signal, like a red flag, because one of the consequences of domestic abuse is suicide, and often that's not recognized when there's a coroner's report or an investigation of a suicide. So actually suicide is part of the hidden health impact of domestic abuse. And like the other panelists, I'm kind of holding my breath with a bit of fear about what we're going to see about the suicide rate when that's finally being reported in the past year. I mean, on a personal GP level, it's not something that I've seen, but the prevalence of suicide is such that it's not something that you necessarily see as an individual clinician unless you work with a high-risk group. I think my psychiatry colleagues and people working within mental health services more generally certainly feel that there's been an increase in suicide.
Okay, this is all incredibly worrying. Raj Bastow's got another question he'd like to ask.
Yeah, I wanted to put Raj Kohli a bit on the spot. I mean, I know Raj very well, and in fact, this is going to hark back to a conversation he and I had about the fact that many senior police officers have complained in the press before the pandemic that they felt the mental health services had basically collapsed and the police were picking up the pieces, and that they were basically a replacement for mental health services. And many patients have complained, or relatives, that when they rang emergency mental health services and said someone is suicidal or a danger to someone, the response they got was call the police. So I wondered, in the pandemic, when some people have been arguing there has been further collapse of mental health services, have the police felt that they have been under even more pressure and are picking up the pieces even more, as a kind of like they're becoming the frontline mental health service in the view, perhaps controversial view, that mental health problems have gone up over the pandemic and mental health services, some people would say, have collapsed. So I wondered what the police's experience, therefore, of that was.
Raj, thank that crippling question. I'm conscious that this is being recorded. I'm obviously apolitical and police without fear or favour. But to your point, yes, I feel policing has fallen into the vacuum created by some of the public sector cutbacks. My view is that, so we know that London is going to get 6,000 police officers, UK police is going to get 20,000 police officers. Personally, I would cash in 150 police officers to have mental health nurses and youth workers, because I think actually that's where we need to support our communities. Me turning up and slapping the old silver cufflinks on them is not doing anyone any benefit. But we are the first port of call when something goes wrong. If someone's having a mental health crisis and there's no one else available, we will come and we will deal with it as best we can. But we still rely on our mental health colleagues to then take over. Until the point that the pandemic started, there was a negotiations with getting the local mental health trust to sit in our control room and triage a lot of what was coming into the control room, because police officers turn up at a mental health incident and again, I think we either do nothing or we do everything, and doing everything means pursuing 136 and all that kind of business. There are far cleverer people in this call that know there's any number of interventions in between doing nothing and a 136 that you can do. Now, police officers are never going to do nothing because something terrible happens, their job's on the line, forgetting the guilt felt for not doing anything. So we're 136ing far too many people. My view is that, and I'm getting warm signals from the local mental health trust, having someone in our control room triaging what they've got, and then saying, well, actually, this person's best placed if you take them home because actually they've got carers there, or ask if they've had the medication, because if they skip the medication, this is what's happening. We're still in the space of dealing with mental health, but the public rightly expect that if there's a crisis, the police will step into that space. And touched on another favourite of mine that Raj will know. People describe the police as crime fighters. Ladies and gentlemen, trust me, we are not crime fighters. We're crisis managers, of which crime is about 25% of what we deal with. And I think it moves into that whole space about what does society want from policing, because it's not about fighting crime. That's 1/4 of what we do. And I did pose a question to Preeti Patel on a Zoom call on Christmas Day of all times, suggesting that should there be a royal commission into policing to understand what is policing in the 21st century. I think she thought I was being cheeky and provocative, and I wasn't. I was genuinely thinking, I think the time is now to ask that question.
That's clearly a really important question, and it's quite a good place to end this, unless there are some pressing questions anybody in the panel wants to put to any of our colleagues. I'll move over to Nick Morris, who's going to introduce Max and is going to wind up the webinar. But I would certainly like to thank all of our speakers for an absolutely fascinating and superb webinar. Thank you all very much indeed. Over to you, Nick.
I'd like to thank everybody for joining us tonight, everyone who's attended, our sponsor Mindspace, Claire for hosting us so elegantly tonight. It's a lot to think about, because those of us who don't work at the hard end learn a lot from something like tonight, and I've definitely learned a lot from every single speaker tonight. I'm going to introduce Max now on a completely different note. Is that I went to medical school in 1979. Max knows what I'm going to say because I warned him about this on Sunday. And at St Mary's Hospital Medical School in 1979, there wasn't occupational health. There was a man called the medical superintendent. He had played rugby for the British Lions. He had been a barbarian. He'd spent his whole career at St Mary's. Stafford, you probably met him.
Indeed.
Cocky.
Yes.
Cocky's job has not been replaced. All the hospitals had a cocky, someone who looked after the mental welfare of everybody from when they were a medical student through to becoming a consultant, and the experience of all the changes in their career. Now, Max, what you've done, I think, is quite remarkable, because what you did through your music therapy, is you took a hospital that got completely hammered by the worst enemy of all, a viral infection that you knew nothing about, like us, 3 months before it happened. And you gave hope to people. we thought your music was so special that back in June, we did a webinar which ended with your version of Over the Rainbow, which was beautiful. But today, do you want to introduce the piece of music that you've recorded that Claire's going to play? I'd be grateful if you can, and thank you for joining us.
Sure. Well, yes, Over the Rainbow was really the result of professional musicians approaching me and to see how we could collaborate together from the European String Teachers Association, how we could play something remotely together as musicians for NHS workers. And it was a very moving time. And it was just really when we were coming out of lockdown. All of this came about from members of staff who had been on the ITU between 4 and 12 weeks or more. We were celebrating in their discharge from hospital with music, and it was almost like a carnival atmosphere. So it was incredible. So I think a lot of my colleagues felt anxiety, not just people who are not medical, because we'd seen our colleagues dropping like flies with the virus, and I've had 2 consultant colleagues who sadly died, and others who've been unwell. So I was playing the violin to them online to support them privately at home, and also release some videos on Facebook. And then the press followed me around for a bit, which was very, very nice. So I could actually spread the word. This lockdown, I for one, have found it very, very, very difficult this time. It seemed to go on forever and ever. And certainly in the hospital, it felt as if the ship was going down just around Christmas time, before the actual peak at the beginning of January. And so I thought I'd play a video which you're going to see called Smile. This is the music that was actually written by Chaplin, but made famous by Nat King Cole. And if you go back and listen to the lyrics, I'm not going to read them out now because I'll probably choke as I describe them to you, because they really do strike a chord. You know, when your heart is yearning, it's time to smile, and actually smiling and music, it does make you feel better. Music actually stimulates the reward centers in our brain, right in the deep recesses, and it's been a fantastic way to actually communicate with people and to patients, and to touch them, not necessarily physically but emotionally. And often there are tears there, but the tears, as all psychiatrists and medical professionals will know, tears are a way of healing. So this was my way of communicating that.
Well, you communicated very well so far. So Max, thank you. Thank everybody for joining us tonight. Next month is going to be a bit of a surprise. I've just started planning it. I'll tell Stafford about this tomorrow, and we'll start putting our plans together. But we hope you can join us next month. We'll be coming out of lockdown. I'd like to leave you all with Max and Smile. Over to you, Claire.
Well, I'm sure you're all feeling this lockdown is even harder than the others we've been through. But I do believe there is light at the end of this rather dark, long tunnel. And so I'm going to play for you now a piece popularised by Nat King Cole and written by Charlie Chaplin. And if I adjust my mask, this is called Smile. Stay safe. Stay sane. And smile.
Well, thank you all for being with us tonight. What can one say after that beautiful piece of music? And to think it came from modern times.
Yeah, incredible.
It was, but thank you all very much. It was a wonderful evening. We've recorded it, so next week, when Claire has a moment, she'll put it on the website, and also we'll get you a direct link to it as well, so you can have it, because I think it was great having the range of different people involved in this tonight. Stafford, you chose really well. The Rajes I know very well, and I think it was a great combination of people. And Robert, you spoke so elegantly. So thank you all very much. And Robert, I'll see you tomorrow.
I'd like to thank everyone too. That was great. A great panel.
Thank you.
Thank you, everybody.
Okay.
Good night. Bye.
Bye.
Bye. Good night.